And I hope, so last but not the least, our last presentation today is Dr. Sajid Jalil. Many of you have seen him in some of the presentations. He was at PSH, he's at Stanford University, and his topic is autoimmune hepatitis and BBC. And at the end of the talk, I do want beside that table, any other table to ask question also. So Dr. Sajid Jalil, please go ahead.
Assalamu alaikum. You can hear me okay? So first I want to thank the organizers, Dr. Bilal Hamid, and this has been a very well organized conference so far. And I want to congratulate the previous three speakers for doing a great job. They've set the bar very high. So I'll go ahead and get started. The topic I was given was autoimmune and primary biliary cholangitis updates from Aasld 2025. So first I'll start with primary biliary cholangitis. This is a abstract that looked at serum IgM levels, whether it has any association with prognosis in PBC patients. So elevated serum IgM levels are frequently observed in patients with PBC, and there have been very few studies examining whether there's any association. So this study from Japan looked at, this is a retrospective analysis. They looked at 427 patients with PBC, and out of those, 273 of the patients had liver biopsy, 154 did not. And they looked at association of serum IgM levels and liver-related events. The liver-related events were defined as occurrence of ascites, varices, hepatic encephalopathy, or hepatocellular carcinoma. And this is the results. So they divided the group into two cohorts, those with elevated serum IgM levels and those with normal IgM levels. The mean age was 58, and there were more male in the elevated IgM levels. The other parameters like biochemical AST, ALT, alpha phos, gamma GT, they were higher in the elevated IgM level cohort. And on the right, you can see the results. The top graph shows that patients who had high serum IgM levels had higher incidence of liver-related events. And even in the bottom two graphs, even in early clinical and pathologically early disease, there was higher incidence of liver-related events. So the conclusion was elevated serum IgM levels can be an independent predictor of liver-related events in primary biliary cholangitis, even in patients with clinical and pathological early disease. Next abstract examines the clinical paradox. In PBC patients, we see hyperlipidemia frequently. And the traditional teaching or assumption has been that this is benign hyperlipidemia and that it is not associated with cardiovascular disease. However, recent studies have questioned this assumption. And to address this, this is a multi-center retrospective cohort study where they looked at the impact of hyperlipidemia on cardiovascular and liver-related outcomes in PBC. So they used the TriNetX database, and patients were divided into two cohorts, those with hyperlipidemia and PBC and those without. They did propensity score matching. The primary outcomes were major adverse cardiovascular events, secondary outcomes, liver-related complications. And these are the study results. The all-cause mortality of PBC patients were low. as well as liver-related events such as ascites, hepatic encephalopathy, SBP, and variceal bleeding were low. But the risk of cardiovascular and metabolic disorders were higher in those patients with hyperlipidemia. So incidence of or rates of ischemic heart disease, stroke, peripheral arterial disease, heart failure, and metabolic conditions like diabetes and hypertension were higher in those PBC patients with hyperlipidemia as compared to those without. So the conclusion was, despite a lower all-cause mortality and reduced liver-related complications, the significantly increased burden of cardiovascular and metabolic comorbidities in PBC patients with hyperlipidemia underscores the importance of more personalized and proactive cardiovascular monitoring. This is another related abstract. I didn't use the details of the study, just wanted to show the results. This abstract looked at the use of statins in these PBC patients to see if it is beneficial. And on the left, you can see that the patients who were on statins had lower rates of liver-related events and decompensation rate as opposed to those who were not taking a statin. So my conclusion from these two studies is patients with PBC don't have benign hyperlipidemia, that it does increase their cardiovascular risk, and statins are a great way to treat them because it not only reduces their liver-related complications, but also reduces their cardiovascular events. This next abstract looks at early alkaline phosphatase normalization using a combination of UDCA and bezafibrate. So UDCA is the first-line treatment for PBC, and early normalization of alkaline phosphatase has good prognosis. So within 1 year of improvement or normalization of alkaline phosphatase is associated with better survival. Bezafibrate improves liver biochemistry, and typically it is used as a second-line agent in patients who are incomplete responders. In addition, and it is given in combination. So the investigators here looked at whether early combination therapy versus UDCA alone can impact ALP normalization. And here's the study design. So they had one group with UDCA alone, one group with UDCA plus 800 milligrams of bezafibrate, and the third group with UDCA and bezafibrate 400 milligrams. And after 6 months, they were all converted to 400 milligrams of UDCA. And then they looked at the results. And you can see the baseline characteristics were pretty similar in all three groups, except BMI was lower in the high combination cohort. And these are the results at 6 months. The rate of normalization, ALP normalization, is 100% in the high combination group as opposed to 83% in the low combination group versus UDCA alone. And if you look at figure 4, which is complete response, 57% achieved complete response in the higher combo group as opposed to 47% in the low combo group versus UDCA. And the decline in ALP is much steeper, if you may, in the high combo group. Figure 5 shows you the rates change or improvement in pruritus from baseline to 6 months later. You can see after 6 months, 100% of combo group had resolution of pruritus as opposed to a smaller percent in the 6 months in the UDCA alone group, 88%. So in conclusion, upfront combination therapy with UDCA and bezafibrate significantly improves um, ALP normalization as compared to UDCA alone. And the clinical impact of early ALP normalization should be investigated in future studies because it may have significant prognostic factor in terms of liver-related events. Next topic, we'll talk about primary sclerosing cholangitis. So this is a study looking at role of MASLD in driving fibrosis in PSC patients. So as you know, the MASLD is associated with increased risk of hepatic fibrosis, HCC, liver transplantation, and all-cause mortality. So the investigators wanted to see the effect of MASLD in PSC patients. So this is, again, a retrospective study using Trinetics database. Adults over 18 years of age diagnosed with PSC between 5 to 20 years ago were identified and divided into two cohorts. There were 506 patients with PSC and MASLD, and over 4,000 patients without MASLD. The primary outcome was fibrosis progression. The secondary outcomes included HCC, liver transplantation, and all-cause mortality. And here are the results. So the cohort with PSC and MASLD were at risk of fibrosis progression 8-folds compared to PSC alone. Other outcomes such as HCC, liver transplantation, and all-cause mortality were similar in the two cohorts. And they have depicted the same results in bar chart and risk ratio here, essentially showed the same thing. So in conclusion, MASLD is associated with 8-fold increased risk of fibrosis progression in PSC, suggesting a synergistic liver injury. And incorporating routine metabolic risk assessment and lifestyle modification may help mitigate liver disease progression in this subgroup. And further prospective studies are recommended. Next, we'll talk about autoimmune hepatitis. So this abstract looked at pregnancy outcomes in patients with autoimmune hepatitis taking azathioprine versus those not taking azathioprine. So women with autoimmune hepatitis have been treated with azathioprine throughout their pregnancy. However, the studies that we have are smaller studies, and there's a theoretical risk of increased risk of teratogenicity. So this study looks at that. This is a Trinetics database. Again, women aged 18 to 15 were identified with autoimmune hepatitis. Comparison groups were azathioprine versus no azathioprine. And these are the results. This shows the baseline characteristics before matching and after matching. You can see after propensity score matching, the baseline characteristics are pretty comparable. And outcomes such as preterm pregnancy, abortion, gestational diabetes, eclampsia, preeclampsia, or suspected teratogenicity were similar in both cohorts. So conclusion, women with autoimmune hepatitis on azathioprine have similar pregnancy outcomes as those who are not taking azathioprine. So this is very reassuring. Although we knew that, but this large retrospective study kind of verifies that. This next abstract talks about second-line agents. So about a third of patients who are with autoimmune hepatitis end up discontinuing azathioprine because of intolerance. Both 6-MP and mycophenolate mofetil MMF are second-line options, guideline endorsed, but head-to-head comparison is scarce. So the aim of this study was to compare their effectiveness and safety in a large multi-center cohort. So this study includes 211 patients from 11 centers in Europe and Canada. And they included patients who were azathioprine intolerant. They had 106 patients with 6-MP and 105 patients on mycophenolate. They did propensity score matching. Primary endpoint was complete biochemical response. Secondary endpoint, treatment intolerance, need for third-line therapy, changes in liver stiffness, and long-term outcomes. And these are the results. So you can see about a third of the patients who were on azathioprine ended up stopping it, and they were converted to 6-MP or mycophenolate. The largest share of patients on 6-MP ended up stopping treatment due to intolerance, as compared to a smaller percent of mycophenolate. And you can see the biochemical response was in the two groups. The conclusion was both 6-MP complications. Yet data on pregnancy outcomes following liver transplant is scarce. So this study aims to analyze the impact of autoimmune hepatitis-related transplant on pregnancy and fetal outcomes during and after pregnancy. So this is a large retrospective analysis using the Transplant Pregnancy Registry International between 1985 through 2024. They had a total of 400.
Yeah, sir, is there internet issue on his side, Dr. Sajid? His side, okay. I think he's almost at the end of it. They were only...
In 1 year in the AIH, 11% versus 4%. Other outcomes such as labor type, spontaneous induced C-section, or live birth or miscarriage rate were pretty similar in the two cohorts. On the right, you can see the bar graph showing the immunosuppression. Up to 10% of the patients were exposed to mycophenolate as soon as they found out they were pregnant. They were switched to a different immunosuppression. The larger group were on prednisone. Neonatal outcomes, the AIH cohort babies had high rates of jaundice and NICU admission as compared to control group. And transplant outcomes were similar, except graft loss was higher after pregnancy, about 24% versus 13% in control. So the conclusions were pregnancy outcomes are similar in women following liver transplant for AIH compared to other diagnoses. Neonates of AIH patients had higher rates of neonatal jaundice and NICU admission. AIH patients also displayed higher rates of graft loss after pregnancy, possibly due to shorter liver transplant to conception intervals. And despite higher exposure to mycophenolate, there was no differences in birth defects, miscarriages, or stillbirths. So take-home points, serum IgM levels are an independent predictor of liver-related events. PBC patients with hyperlipidemia are at significantly increased risk of cardiovascular burden. Statins can be used to protect against decompensation in major liver-related events. An upfront combination therapy with UDCA and bezafibrate yields significant higher 6-month ALP normalization rates than UDCA alone. MASLD is I think we skipped this. No, we did. MASLD is associated with 8-fold increased risk of fibrosis progression in PSC, suggesting a synergistic liver injury. Women with AIH on azathioprine had similar obstructive pregnancy outcomes as women with AIH, not on azathioprine. Both 6-MP and MMF achieved comparable long-term biochemical responses in patients with azathioprine intolerant AIH. And pregnancy outcomes are overall similar in women following liver transplant for AIH as compared to other diagnoses. I want to thank you for your attention. I am happy to take any questions.
Thank you. Thank you so much, Dr. Sajid Jalil. Questions for the audience. It was very clinically relevant about many things that we see in our practice.
Bilal, I think you're muted.
No. Can you hear us, Dr. Sajid? Sajid bhai, aapko awaaz aa rahi hai?
I can hear you now.
Okay.
With a little echo.
Okay. First question I have that the IgM level in your clinical practice, the presentation was
I'm sorry, I'm having trouble hearing you.
Yeah, we cannot hear Bilal at all.
Can you hear us?
Bilal, you are muted, I believe.
No, we are not muted. I think, let's see. Yasser, is there muted?
I can hear you now.
No, it's better now. I can hear you.
On. Okay, can you hear us? So Sajid bhai, the first question about your, the first abstract about the IgM level, is it at the time of diagnosis or you check it on a regular basis? What's your clinical practice for the IgM level in patient with PBC?
You know, this really raised my eyebrows because I've noticed here elevated serum IgM levels, but I've not paid attention until this abstract. I read this abstract. So I'm going to start checking it more. And based on this study, it was early at the time of diagnosis.
Yeah, because I think some people check it on a regular basis, but not all the time. But it's an interesting thing that on the presentation, whether that was can able to do it or not. Any other questions from the audience? Please, do you have a mic to our, can we pass the mic to one of our, please go ahead.
Assalamu alaikum. It was a very nice presentation, Dr. Sajid. The only thing that comes in my mind is in cases of PBC, is there any specific cutoff of lipid levels at which we need to start the bezafibrate or statins? Or is it the usual level of ASCVD classification that we used in other cardiovascular disorders?
Yeah, I think it's the usual ASCVD lipid criteria that we use for cardiovascular mortality. So there's no cutoff that they came up with in this abstract basically the same criteria we'll use for cardiovascular related
Professor
statin
Altaf.
therapy.
Right. Thank you, Sajid. An excellent presentation. Good selection of abstracts. We hope
Thank
to
you.
see you next time in person at the next Liver Summit. Um, Bezafibrate is not available in Pakistan. So what I'm doing here is using fenofibrate in its place, and I understand it works equally well. And I've seen the results in either partially responsive patients or upfront dual therapy, UDCA plus fenofibrate, and it works very well. I'm not using it for lipid control, I'm using it for control of cholestasis. So even with normal lipid profile, I'm using it for cholestasis. Are you doing the same, or you are only using in those patients who have dyslipidemia?
No, actually, I'm using more and more fibrates in my practice. If alkaline phosphatase doesn't improve despite patient being compliant and taking UDCA, and certainly if they have a higher lipid profile, which we routinely check every 6 months, I'm trying to be more aggressive. Plus, I use statins pretty aggressively. So. A lot of these patients also seem to have metabolic dysfunction, so we have to definitely consider statin as part of their treatment armamentarium.
In the US also, we just recently had 2 approval of new medications, seladelpar, and before that we didn't have bezafibrate, so we had some patients going to Canada to get it, or we were using fenofibrate. I had a lot of patients on fenofibrate, but now with the second line therapies have changed, like it is, like I've seen like complete normalization, the pruritus have changed, has improved, so this has changed the field. I'm not sure about the prevalence of BBC in Pakistan and whether there would be need for these second line therapies in the future, but we can see how much improvement patients have, the quality of life, the lipids and everything, so that has changed. So thank you, Dr. Sajid Jalil, for another excellent session. Thank you all the audience and our